So we're starting, sir. Good evening, respected doctors. On behalf of Pulses Derma Private Limited, it's my privilege to warmly welcome all of you to this scientific masterclass. Founded in 1984, Pulses Derma has remained dedicated exclusively to dermatology for over 4 decades. Guided by our philosophy, passionate about dermatology, we strive to bring innovative, quality driven, and science backed solutions that help dermatologists deliver the best possible outcomes for their patients. Our vision is to be a trusted partner in advancing dermatological healthcare through innovation, scientific excellence, and meaningful collaboration with the medical fraternity. We are happy to introduce the Derma Masterclass series, Chapter 3 on Update on Sexually Transmitted Infections, Modern Management, an academic initiative comprising 25 webinar sessions designed to systematically cover the major chapters from the dermatology textbooks. Our objective is to provide a platform for academic enrichment through expert-led discussions, clinical insights, and recent advances. So today, we are honored to have Dr. Kaleem Khan, consultant dermatologist, PD, Hinduja Hospital, with us today. Dr. Kaleem Khan had completed his fellowship from Toronto Western Hospital, Canada, and the National Skin Center, Singapore. Associated with 14 publications and 5 chapters in dermatology textbooks, Dr. Kaleem Khan is the assistant editor of Atlas of Vulvovaginal Disease in Darker Skin Types. Dr. Kaleem Khan is associated with institutes like PD Hinduja Hospital, Mumbai, Wokhart Hospital, Surya Mother and Child Hospital, Santa Cruz, and Skin Indulgence in Andheri West. His areas of interest: regenerative medicines, inflammatory dermatosis, and the neurotoxins. I'm confident that his expertise and insights will make this session highly informative and beneficial for all of us. We look forward to an engaging scientific discussion and a rewarding learning experience. Thank you. And now I have the pleasure of inviting Dr. Kaleem Khan to begin today's session. Over to you, sir.
Right. Thank you. Thank you for having me. Um, it's a great thing to be part of this web series, this education initiative that Palsons has taken. And I think it's really something that was missing, because now you get some good information in something which is a concise manner. So it's great for students. I thought it was a great initiative, and I'm glad to be part of this. Right. So let's just jump on to the topic for today that I'll be covering. I hope everyone can see the screen.
Yeah, it's visible, sir.
All right, perfect. So I'm talking about updates on sexually transmitted infections, the modern management. And before we get into the talk, I thought that there would be some important disclaimers that and some context setting that I wanted to lay out today for you. So the important thing is that I'm a practicing clinician in the city of Mumbai, in an area called Andheri. Okay, I'm also affiliated to many hospitals, but they're not teaching hospitals. So I'm not really doing a lot of academic teaching wise, but I'm more clinically oriented, and I see clinical patients from a private practice point of view, not a teaching institute point of view. So this topic today can be one of the most boring topics ever if you're going to talk about names of drugs and the doses that we have to do for STI management. So clearly we are not doing something like that. I've tried to incorporate information that will help both the students by some important questions and practicing people so that they get an update of what is new in the STI management over the last few couple of years. You know, so that's one. Secondly, I'm not going to cover HIV as part of STI because that's a whole different thing. Thirdly, just to put it out there, a lot of the times when you read about updates in STIs, the information is mostly driven by Western world, Western literature, which may not be very applicable to us, or the understanding over there is different from what is happening here. So that brings us very nicely to this first slide of the talk, and that is wanted to list out what are the important organizations that we need to look for when you want to update yourself on STIs. This is a good thing for the students. I would have loved to know this when I was still doing PG, probably 2 decades ago. Right. So of course, everyone knows the WHO and the UNAIDS, which is the United Nations Program for HIV. The most important one is the CDC because they are the ones which present the information. The Indian counterpart for the CDC is the NACO, which is the National AIDS Control Organization, and they run the NACP, which is the National AIDS and STD Control Program. And among that, there are multiple things that they do. We will try and see the important things that they are able to put up for us as Indians to follow. CDC first published guidelines all the way back in 1982. And since then, they regularly update their recommendations. But the major updates came all the way back in 2002, then 2015, and then as recent as 2021. The NACO follows a similar projected timeline where they have updates coming in regularly. Although they started in 2007, they updated in 2014. There was another good update in 2018. But the latest one, 2024, is what we are following. It's currently in the phase 5. All right. So why is it important to even discuss STIs is because there has been a dramatic change in the STIs over the last probably a decade and a half. This is WHO data of 2020, and this talks about the burden of curable STIs. We are talking about mostly bacterial and the protozoal trichomoniasis. So that's syphilis, gonorrhea, chlamydia, and trichomoniasis over the entire globe, of which India and the Southeast Asia falls in the 3rd spot in the incidence of new cases. And this is between the adolescent age group of 15 to 49. So it's definitely alarming because you would think that with newer antibiotics, with newer investigations, with more focus on trying to eliminate the disease, we want to probably look at a decline rather than an uptick, right? And why is that happening? Why is that happening? We'll briefly talk about it, but the clinical implications is that there's the global resurgence that we were talking about with 374 million new cases. And this is not just globally, but this is happening even in India. This is happening in India. So I practice in Mumbai, and in my private practice, although it's not even a STI clinic kind of practice that I have, even then I get to see maybe a gonorrhea once in 2 months. We'll see some syphilis in a similar time frame, and we are seeing more and more syphilis cases nowadays. So it is definitely happening even here, and maybe because of the change in sexual behavior, dating apps, or there could be many other reasons of this resurgence. There's something about the pre-exposure prophylaxis that's happening now, which we should be aware of, and something called the doxy-pep. And I thought that we should talk about it. This is important both from the student's point of view, where you might be asked about this in the exam, but also for practicing clinicians, because this is something that is being done now, or this is being recommended by the CC. So what is PrEP? This is pre-exposure prophylaxis. And of course, it means that you're using some sort of medication, that is the antiretroviral medication, to prevent the acquisition of HIV, right? And this is actually a fixed dose combination of tenofovir with emtricitabine. And depending upon the salt of tenofovir, it can be either 300 milligrams or 25 milligrams. But the new addition is the long-acting injectable cabotegravir, which is actually a deep IM injection, which is given The first 2 doses are 1 month apart, and then subsequently it's every 2 monthly. And there's another addition, a subcute injection, the lenacapavir, which is every 6 monthly. So these two are new additions to the treatment profile as part of PrEP. So who would you give pre-exposure prophylaxis to? This is actually in short to all individuals which are high risk, whether they are adolescent or they are adults, any high risk individual. So these are people who are maybe preferably performing condomless sex. They are MSMs, they are high risk individuals because of high risk behavior. So anybody who is at a risk of acquiring HIV can be given or should be given PrEP, that is pre-exposure prophylaxis. But who should you not give pre-exposure prophylaxis? People who have active HIV infection. So those who have been actually documented to have active HIV, you cannot give them PrEP. They need to be on full dose medication, antiretroviral medication. Patients who have altered creatinine clearance, they have some renal dysfunction. Sorry, that went a little faster. Right? They cannot be given PrEP because the medications are cleared through the renal function. People who are on fillers, implants, and silicones in the buttocks and the hips, because if you're giving IM injections, the absorption may be hampered. And lastly, there could be drug-drug interactions, so anti-epileptics and rifampicins or rifamycins, because they are hepatic enzyme inducers. You might want to check. What is happening because of PrEP is that unfortunately there's an increase in the STI rates. And this is happening because patients are now at ease that, oh, my chance of getting HIV infection is less because I'm on PrEP. So I don't need to use a barrier contraception. So more and more condomless sex is becoming prevalent. And because of that, there's an increase in other bacterial STIs, right? The problem is not that the condom is only helping with HIV, but also other STIs. So if you don't have a condom, you're probably increasing the risk of other diseases like syphilis, gonorrhea, chlamydia, and we are seeing that. Also, an important point to note is because the PrEP medication suppresses viral replication, the development of antibodies, that is seroconversion, is delayed. So they might get false negative results. Something with this slide which is jumping around, but we were on the fact that you can get false negative reports because patients are on PrEP. So these patients need to be tested simultaneously with an HIV-1 RNA test and the 4th generation antigen antibody testing, right? So this was something about PrEP, that is pre-exposure prophylaxis. But what is post-exposure prophylaxis with doxypep? So doxypep is doxycycline post-exposure prophylaxis. And this is very simple. You just give one dose, single dose of 200 milligram doxycycline within 72 hours of condomless sex. Ideally 24 hours, but 72 hours is the window. And who should you give it to? This is usually people who have had at least one bacterial STI in the last 1 year. So they've had a history of syphilis, chlamydia, or gonorrhea in the last 1 year. And gays, bisexuals, or MSMs, or transgender women, all of them can be given single dose 200 milligram oral doxycycline, ideally within 24 hours of condomless sex. This is shown to reduce transmission of chlamydia, syphilis by almost 88% and gonorrhea by almost half. Right? So it seems to be working really well. But I don't know, we'll talk a little bit more about it later on in the talk today, right? The other thing that is changing a lot in the STI management is testing, right? So diagnostics. Gone are the days that we are doing culture and microscopy to see the organisms. We are now using PCR-based syndromic panels so that we can simultaneously detect multiple pathogens. All of this with a simple non-invasive swab or a urine sample. And we can see if there is multiple infection happening in the same patient at the same time. Right. Most of this is NAT, that is nucleic acid amplification tests that are there. What about syphilis? Syphilis, that was the slide before. We are following something called as the reverse syphilis or algorithm. This can again be an important question in your exams for students who have joined in. And traditionally, what we have done is when we suspect syphilis, we will do non-treponemal test. So we'll do either VDRL or RPR. We will see whether it's positive. If it's positive, then we'll confirm it by doing a specific test of syphilis, right? Treponemal test. Now what they're saying is just do the exact opposite. Start off with a specific treponemal test. So there is TPHA or TPPA. In the US, they do TPPA. What is the difference? So TPHA is heme agglutination. Here they do particle agglutination where they use gelatin or synthetics, some synthetic latex particles for the test, but essentially they are the same. And if you get a TPHA or a TPPA positive, then you know you're dealing with syphilis because false negatives are very low. You can then do the non-treponemal test and prove that it is syphilis and then start them on treatment, as opposed to what we were doing, you know. So let's see what is the difference in the guidelines between 2015 and 2021. I'm going to discuss the guidelines changes of both the CDC and the NACO. So let's start off with the CDC, right? So we'll probably take up the infections as we go along. So what are the changes in gonorrhea from 2015 to 2026 now, but they had updated in 2021. So what happened was in 2015, they said, oh, azithromycin 1 gram is awesome. Let's just give 1 gram azithromycin as most STIs. And now we are getting to see the side effect of that. And that Neisseria gonorrhea developed resistance to almost all antibiotic classes. So now what are they saying? First line drug management for gonorrheal infections is ceftriaxone monotherapy in the bum. So deep IM injection, 500 milligram. For higher weight patients, it is more, double the dose, but normally it's 500 milligrams single dose ceftriaxone deep IM. If there is a possibility of chlamydia co-infection, you might give it with doxycycline. We'll talk about it later. There are also some newer drugs. This is again for students. They might ask you in the exam. 2 novel antimicrobials that are being used. Sorry, that jumped. That is the zoliflodacin. And the other one is the gepotidacin. Everyone says that biologicals have a weird name. They're tongue twisters. They have no idea what these newer antibiotics are called or the newer antifungals. They are absolutely ridiculous. They are brain twisters, not even tongue twisters. But yes, these 2 drugs are important because they have completed phase 3 trials and they are pretty good. What about chlamydia? Chlamydia, the drug of choice is doxycycline, 100 milligram twice a day for 7 days. Those days of single dose azithromycin, long gone. What about mycoplasma? Mycoplasma, so I passed out in 2009. That was a long time ago. And at that time, mycoplasma was not even considered. It was probably the 3rd or 4th causative agent for non-gonoccal urethritis. Everybody just dismissed it. Oh, okay, if you couldn't remember what were the organisms, you could just put in mycoplasma in there and they'll be like, okay, yes, we will take it kind of thing. But now, mycoplasma is recognized as a leading cause of non-gonoccal urethritis, right? And with staggering rates of macrolide and fluoroquinolone resistance, all of it because of single dose 1 gram azithromycin, right? So now what they're saying is, if you want to manage mycoplasma, you have to do resistance testing first. If you do resistance testing and it is sensitive to the macrolides, that is azithromycin, you first give doxycycline and then give azithromycin. If you don't have resistance testing, that happens very commonly in India, then you don't give azithromycin, you assume that it is resistant and you give doxycycline 100 milligram twice a day, followed by moxifloxacin 400 milligram twice a day, single dose for 7 days, right? So it is 100 milligram twice a day for 7 days, followed by moxifloxacin 400 milligram single dose once a day for 7 days. So it's a sequential therapy with 2 antibiotics. Thankfully, not much has changed for management of syphilis, but there is something that has happened. We'll discuss just immediately few slides down the line. But the treatment of choice for syphilis is still benzathine penicillin, and that's what you need to give. What has changed is that it's no longer following the pattern that we know classically syphilis to follow: single painful ulcer, single painless ulcer, Dory flap sign, all of that. It has changed. Most of the time, almost 50% of the times, it is painful, and more than 30% of the times, they are multiple ulcers. And this is happening across the globe. Multiple case reports, even from India, that it is not following the classic description that we are aware of. The update that was there in the CDC was for neurosyphilis, that you don't need to do lumbar puncture for patients who are latent syphilis and they are showing a decrease in the serology after giving treatment. So they want to reduce as much paperwork and as much added investigations. So this is their way. Just don't do the lumbar puncture for these patients. What about LGV, lymphogranuloma venereum? Sorry, I don't really know what's happening with these slides. They seem to be really jumping around. Sorry, my bad. Let's talk about LGV. We know that it's caused by Chlamydia trachomatis, right? And what is happening is that the presentation has changed. Nowadays, you need to think about LGV if you're seeing anorectal syndrome, that is hemorrhagic proctitis, anal spasms, and perianal ulceration. So you no longer expect for patients to come with inguinal buboes and that kind of classical presentation. This is more commonly seen in MSMs. So you would see the anorectal syndrome. And many a times it can be so bad that you might actually think of Crohn's disease as a differential for these patients. The other thing that we saw in 2022 was monkeypox. I seriously don't know what's happening. I don't know what is happening here. Monkeypox was the outbreak that shook the world. Everyone sat up and took notice of this infection. And it presented classically as painful pseudopustular lesions with central necrosis and umbilication in the anogenital and the perioral region. And this was very actively targeted by the CDC, by the WHO, and we could get it under control before it became a global menace. And in some part, it was to do with vaccination, because monkeypox, a variation, was there quite some time ago, and we had developed a vaccine for it. We started vaccinating patients, and we could reduce the infective burden. But what it also did was it changed the clinical presentation. So now you have to have a high degree of suspicion to detect monkeypox in these patients. By the way, we don't call it monkeypox anymore. We just call it mpox. What are the changes in HPV and HSV? HPV, very importantly, we are now recommending vaccination for everyone, including boys and MSMs. Previously, it was only for adolescent girls and younger women to prevent cervical cancer. No longer are we restricting it to women. We can now give it to boys and MSMs. And also, if there has been a surgical excision of a high-grade intraepithelial neoplasia, you will still give them the HPV vaccine. We are not going to say that, oh, there's already an intraepithelial neoplasia, so what is the point of giving the vaccine? No, we give the vaccine. So this was the change for HPV. With HSV, only thing is we have only one antiviral that works. That is the acyclovir, valacyclovir, famciclovir. So of course, there will be some resistance as sometime developing. So we are looking at alternatives. These are the two that we should keep in mind, at least from the exam point of view. This is what they will ask. That is pritelivir and emnavivir, whatever. You know, my brain is already gone. So what about protozoal infections, trichomoniasis? Here we are saying that you need to give extended 7-day course of metronidazole, 500 milligram twice a day for women. For men, it is still the same, 2 grams, single dose, that's it. What about vulvovaginal candidiasis? What they have done is for uncomplicated vulvovaginal candidiasis, they have now added an option for various OTC drugs. Previously, it was only clotrimazole. Now we can even use miconazole and teoconazole, which is available OTC there. In prescription azoles, they have added butoconazole and I think it was terconazole. With recurrent vulvovaginal candidiasis, there is an initial phase and maintenance phase that they have added this time around. And if you are suspecting non-candida species or azole-resistant species, they are recommending boric acid or nystatin tablets. Lastly, for PID, pelvic inflammatory disease, which is a complication for untreated or long-standing STIs, especially gonorrhea. So they have added metronidazole. So now they recommend that you need to add 500 milligram twice a day for 14 days of metro, along with ceftriaxone and doxycycline. So this was the update for PIDs. There's a lot of talk and update for transgender patients in STIs because now there is a lot of, say, awareness about it and people are talking about it, and that there are a lot of patients going for gender affirming surgeries. Again, this is not something which is happening just in the West. This is happening very much here. In the area that I practice, there are at least 2 plastic surgeons who I personally know are doing gender affirming surgeries for patients at least twice or thrice a month. Okay, so this is happening even here. And why is it important to know? So this was very interesting. So when you were to create a neovagina for a male patient, right, who believes or wants to do a gender affirming surgery as a female, the penile skin inversion creates a moist environment which is lined by squamous epithelium. You know that the mucosa, the genital mucosa, is non-squamous, right? It does not have any stratum corneum. It is mucosa without any keratin. So when you were to create a neovagina with this skin, they would have a completely different skin thing, right? You have to keep it moist, but there is no microbiome which is similar to a normal vagina. The pH is different. So these patients are at a higher risk of HPV infection, the neovaginal condyloma acuminata, or even squamous cell carcinomas are very important. Right? So keep that in mind as when you are evaluating patients for STIs. So I just thought that I'll put you, what is the update? What is happening in the US, right? So the US is trying really hard to battle this surge of infections, the STIs, especially in the younger population. They are showing that the rates are higher in patients less than 25 years of age, so younger population. So what have they thought of? They have this 3-pronged approach that they are trying to promote. One is to neutralize the transmission as source. So that's how the doxypep came in. So if you reduce the chances of infections to spread, you can control the disease. The second thing was, how do you accelerate diagnosis outside the clinical walls? So don't expect patient to come in, get tested, and then know that they have the infection. What can be done at home? So they are doing molecular PCR testing at home. And then lastly, because they had a bad shortage of penicillin, long-acting penicillin, they are looking at alternatives to penicillin, and we'll briefly go over it. So this was doxypep that we discussed a little earlier. You give 200 milligram single dose doxycycline within a 72-hour window period, and you are able to reduce significantly up to 88% for chlamydia and syphilis infections, and about half of gonorrhea infections. So this is what they thought would be a great idea. Let's do it. That's what they're pushing for. What about detection at home? Nowadays, you have patients who can buy these kits. You can do a self swab. You get the results as quickly as within 30 minutes. And then you can do a teleconsult and get a prescription for the same. I have listed these tests on the screen. If you want to take a screenshot, these are US FDA cleared for use at home for STIs that patients can do. And lastly, what about treatment plans? Like I said, they were really facing a shortage of long-acting benzathine penicillin. So they were importing a variation of penicillin called the lentocillin. And this is actually something that contains soy phospholipids and lidocaine. So it cannot be given in patients who have soy allergies or lidocaine allergies. So One more fallback they had was we can give doxycycline. Let's give doxycycline 100 milligram twice a day for 14 days for early syphilis, and late syphilis you extend it to 28 days. Again, this is not the best option. The reliance on doxycycline is too much. I have a strong feeling you're going to see what happened with 1 gram azithromycin 10 years ago. I have a strong feeling that's what's going to happen to doxycycline. And the crazy part is that even they are aware of it. If you go to the CDC guideline website and you read about it, they will be like, yeah, in spite of knowing that there's a high risk of doxycycline resistance, which will happen, we are still recommending it because they are desperate. They don't want the transmission to happen. And for some random reason, I don't know why, in whose brain this came up, that by 2030, there is a goal that they want to achieve of significantly reducing or stopping STIs. I don't know how that's happening. They think giving doxycycline will help. Best of luck to them. Let's talk about NACO. What has India done? The Indian counterpart of CDC, what have they done? So we will subsequently slides, we will see some more in detail, but I thought I'll just list some important points, right? So again, this is more for students to know for the exam, but practically also, these are some things that you will see now coming up more frequently. So I've listed it. There are some terminology changes in the NACO guidelines. So I've listed out these newer terminologies. So one is that they are now preferring to use the word client instead of patient. And at first I thought that is pretty stupid, but the logic that they're giving is that sometimes you have patients who come in who don't really have an active infection. They're looking for more preventive or risk reduction. So calling them patients would be wrong. So you can use the word client. Also, the word client has a lot of stigmatization. So we can use the word client instead of patients, right? So they are going with the word client. There are some newer population groups that have been identified. So we all know high-risk groups, of course, at-risk groups. Transgender, we discussed why they are now becoming an important part of discussion when it comes to STI. But these were very interesting. Something called people living with HIV, that is PLHIV. What is that? Patients who have HIV, they are on antiretrovirals and their suppression rates are excellent. They are absolutely healthy and normal. So these are the people who now get labeled as people living with HIV. There is PLHIV. Okay, so this is one group. People in prison or other closed setting, there is P and OCS. This is another group of individuals that have been identified that are at high risk. You can understand in a closed environment, especially something like prison, where the behavior of patients of the people there is different. They are significantly at higher risk. So this is a group. Bridge population is another important terminology that has been included. And what is this bridge population? These are the group of individuals who have sexual partners in both high risk groups and low risk group. An example would be a person who is going to a commercial sex worker and at the same time, when comes home, has sexual relationship with the wife. So if the CSW has an infection, the person carries it and probably passes on to his wife. So these are the bridge population. Another group of these people would be the migrant workers. They stay at home in the village, but they come to work in the city. They probably pick up the infection in the city and then they go home and give it to the wife. So they are the ones who are responsible for carrying the information or spreading it around, right? Bisexual individuals also play an important role in this bridge population, but it is important to know that this group has been identified and labeled. And lastly, people who inject drugs, that is PWID. Okay, these are the people who obviously are doing some sort of recreational drugs, and because these are also the people who probably overlap a lot with high-risk individuals, people who have high-risk behavior, they are also being identified, and they are also something that needs to be looked or targeted. So these were some important terminologies that have been included or will be discussed. So it's good to know these. What are the newer drugs mentioned in the NACO guidelines, the updated guidelines? Again, this is more from the theory point of view. They might ask you this in the exams. There are so many antifungals, but these two are important because they have been approved or they are in, I think, phase 3 trials are already there. So one is the oteseconazole and the other one I seriously can't pronounce. It is ibrexafunprep or something. So these are the two antifungals that they might ask you. For gonorrhea, these were the two antibiotics. We discussed them earlier. That is the zoliflodacin and the gepotidacin, whatever that was. Antivirals, these were the other two antivirals which are being discussed a lot. That is the pritelivir and the emnavir. But there are quite a few others who are being explored, and also for resistance or for co-infections you want to look at. Some of them are prodrugs, like this brincidofovir, which is a prodrug of cidofovir. Similarly, another prodrug of omniclovir, which is the valomyclovir. All right, so these are some drugs. If you want to take a screenshot of these, this will help you in your exams later on. Like I said earlier in the start of the slide, we are currently in the phase 5 of the national program laid out by the NACO, and they have made these important subheadings which they want to focus on in the phase 5, including the delivery systems. They have updated the color-coded kits. They are talking about presumptive treatment, partner notification, and also management of sexual violence. Right. So these are some very important things, something which are being tackled. It's great to see that being included in the national program. So it's a huge, probably, I think it was a 167-page document that I went through. It's very comprehensive. So I thought I'll just pick up some of the important points that will help you in everyday practice. And also these could be some good exam questions if somebody is asking me, right? So they talk about dual elimination, which is both HIV and syphilis follow the same transmission route from vertically from mother to child. So if we can probably tackle that, so that's what dual elimination focuses on. They're also talking about universal screening, Sambhun Suraksha strategy, where you have one-stop centers. Syndromic kit modifications, where they have added and updated the drugs and added one more. There's also a focus shifting away from just bacterial STIs to viral STIs. So we'll probably focus on HSV and HPV infections and not just the bacterial ones. Traditionally, that was being done. They have updated drug regimes in accordance to world updates. And of course, they have also introduced transgender health as part of the management. So let's talk about these 2-3 things. One is that dual elimination. Like I said, since both of these diseases, that is HIV and syphilis, share the identical transmission routes, if we are able to catch both of these and treat them, nothing better, right? So there's a dual screening and synchronized treatment program that NACO is running by these dual rapid diagnostic test kits. It's a single point of care finger prick blood test. It screens for both HIV antibodies and syphilis antibodies simultaneously. And the best part is if anyone tests positive for any one or both, you don't have to wait to finish a treatment for one and then give the other. There is a fixed dose regime for treatment for HIV. That is the tenofovir, lamivudine, and the dolutegravir combination. And for syphilis, of course, you have to give the benzathine penicillin. Now, all of this treatment is available for free in the clinics run by NACO. Okay, patients don't have to pay for this, but they have to register and they have to go there and do the test. And once they are registered and they are officially there, they get the treatment for free. The other thing that I thought we should discuss is the syndromic case management, because this is something which is quite popular with the examiners, but it also has a strong impact clinically. Okay. So first, what is the syndromic case management? What is the syndromic case management? In India, the number of doctors is very limited. So the doctor-patient ratio is very high. And that too, the doctors are concentrated more in the urban areas. But this infection, the STIs, can be deeper into the country in places where the medical professionals are unable to go. So then you have these ancillary people who end up going there. So that is the Anganwadi workers or the helper people, right? So they find it difficult to identify whether it is a gonorrheal infection or it is a non-gonoccal urethritis, or they can't make an accurate diagnosis, but they do know symptomatically that the patient has this. Okay. So what was decided was that if a patient has a group of symptoms, they will be part of one syndrome. So like that, there are about 8 syndromes. So there is the urethral discharge syndrome or the vaginal discharge syndrome. There is the genital ulcerative disease syndrome, anorectal discharge syndrome, lower abdominal pain, and painful scrotal swelling syndrome presentation that is there. And why is this important is once you have a syndrome that is defined, they have color-coded kits that you would give for a particular syndrome. Okay. So the kits are also, up till now, they were 7. So they have upgraded and got the new kit, that is kit number 8 in the 2024 guidelines. But up till now, there were 7. They were color-coded. And I have tried to show you in this picture that is there how the kits look. So the kits are actually pre-packaged kits. And they have the name of the drug, the quantity inside it, and they also have the indication for what the kit is for. So all you have to do is identify the symptoms, put the patient in a syndrome, and each syndrome has a kit. So if the patient has some sort of urethral discharge, we don't know whether it is gonococcal or non-gonococcal. That is a discharge. There is a kit for the discharge. Just give the gray kit. Cool. That's how easy it is. What they try to do is try to maybe even over-treat, but try to make sure that the infection comes under control. And it is something that even an Anganwadi worker or somebody who's going deep into the interiors of the country, where literacy may be a problem, identification may be a problem, but treatment should be given, making the treatment available, improving the patient outcomes. That is being done. Okay. So in the exams, they ask you what are the color codes and what are the names of the syndromes. And usually they don't ask what each kit contains, but okay, it's good to know. Right. So this is what I was saying. It was always syndromic presentation. Now they've made it extended because they've added one more, and they have definition for what is included in the syndrome and what are the changes, right? So this is it. What was the change from 2014 to 2024? What is the change? Basically, they have increased the dose of cefixime from 400 to 800 milligrams for the gray kits and the yellow kits. And doxycycline in the blue kit has been reduced from 15 days to 14 days because the number of capsules is reduced from 30 to 28. And lastly, because we discussed that because of 1 gram azithromycin, a lot of resistance has happened. For the black kit, they have excluded azithromycin completely. They've just removed it. And lastly, the new one, that is the anorectal discharge syndrome, that is the brown kit, kit number 8. That is a new kit which has cefixime and doxycycline. Similarly, in the NACO guidelines, they have updated not just the drugs in the kit and the syndromic presentation, but also they have changed the drug dosing, recommended drugs, and added new conditions which are treatable by the clinician for as an STI, right? So there were some alternate recommendations, and newer treatment indications. I've tried to put this in this chart. So if you want to take a screenshot, this would be a great time to take the screenshot. This is really what is the difference between the 2014 and the 2024 with the clinical changes that are there. In this enteric epididymitis was not there in 2014. So they have added that. And this is more for MSMs, obviously, who are insertive partners or heterosexual men who practice unprotected insertive anal sex. Because the enteric organisms can go through the urethra, travel up, go to the testes, and then give epididymitis. Okay. And like I mentioned, 2009, mycoplasma was nowhere there. So of course, in 2014 also, it was not featured in the NACO guidelines. But in 2024, mycoplasma genitalium is mentioned as a two-stage therapy that we discussed, doxycycline followed by moxifloxacin, because no one does testing here. Okay. This was the second slide of the same. What are the updates in the NACO guidelines from 2014 to 2024? And here they have added for genital herpes treatment options for recurrences. And previously only acyclovir was mentioned. Now they have also mentioned you can use valacyclovir or famciclovir. So these are some of the changes in the NACO guidelines. We discussed some of the changes in the CDC guidelines. We discussed some newer terminologies. We discussed what are the changes in the STI profile over the last probably 1.5 decades. So with that, there is a small quiz that is organized for you people to take. The link should be there in the chat box. Please go in the chat box and see. If you are able to take the quiz, great. We will run through what the quiz answers are if you're interested. And I think the top 3 people who score the highest also get some prize. There are 10 questions. No, there are 7 questions, 1 mark each. One question has 3 points. There's one specific question. And there's one question which is a little out of syllabus, what we discussed today. It's not what we discussed today, but it's a Google question. If you know, you know. So let's see. Let's see if you guys do it. Okay. I don't know how to see this. How are you guys going to do the...
Sir, shall I show the QR code here?
Yeah, sure. However you are going to do it.
Okay. Just I'm sharing the... Yeah. So by scanning this QR code, you can also be redirected to the quiz link.
Also, you have given in chat box.
Yeah, I think it's there in the chat box. Yeah. So let's take about anywhere between 2 to 5 minutes to do the quiz. Team Palson, how will we know the results or whatever the quiz outcome is? You guys have your software for it?
Sir, post meeting, you can download the responses from your end.
Post meeting?
Yeah.
Oh, okay. Oh, if there
Or
was one
now also you can check the responses.
on my
Yes.
thing.
Yes.
Okay, so how do I do that? How do I check responses?
Go to the drive link.
Yeah.
And then open the Google form and you can check the responses.
I've actually opened the Google form.
Okay.
Do I have to submit it?
No.
How do I see it?
Sir, go to your Google Drive where you have created
I
the
have
link.
to go to my...
Yes.
So where will I see it? Where will I see it?
Go to that Google form. You can check the responses will be coming.
Oh yeah, there it is. There it is. Yes. So up till now, I have only one response, and that person has scored 8 points. That's pretty cool. Nice. So we'll wait for about a minute or two more. There are 28 responses for the quiz. That's pretty interesting. Nice. We'll wait a couple of more minutes. Then we'll run through what the question answers were. Um, and then we'll call it a day. There is one last slide remaining on my presentation. And then it's done, right? So
And if anyone is having any query, feel free to put it on chat box. We'll be happy to take this up with Dr. Kaleem.
sure, I'll try to help you as much as I can. If you have any specific doubts, queries, please put it in the chat box. Nice. Now 35 responses. That's pretty cool. All right, so we have last 5 minutes, right? So should we call it a day? I've got about 40 people who have responded to the quiz.
Sir, please share that response sheet so that I can check and I can announce the winner's name.
All right.
So, okay.
I will give it to you. Um,
No
I will,
need to take it now, sir. You can after the
sure.
program you can download it and
I will email it to you. Done.
yeah.
So should we discuss the answers also, or
Or
we are,
shall I share the questions here?
uh, sure. Okay. Let's share the questions. Come.
Yeah.
I thought
Also,
I'll
sir, in chat
have,
box, there is one question has come up. If you can help with the answer.
okay. So first let's finish the quiz, then we'll do the thing.
Sure.
So I have the questions with me. Since you guys all gave the quiz, you already know the questions. So the first question was, what is the primary rationale of using enhanced syndromic case management? And everybody got it right. It is obviously, it allows for immediate treatment based on clinical patterns. That's the correct one. The second one was when managing painful scrotal swelling in a man who practices insertive anal sex, what additional causative agents should be considered beyond standard STIs? And a lot of you got it correct, and that was enteric organisms. That's exactly what I was telling you a few slides ago. For MSM having epidermoorchitis, you need to look out for enteric organisms. According to the 2021 CDC STI treatment guidelines, what is the recommended first-line treatment for uncomplicated urogenital gonorrhea? And we said it was the single-dose ceftriaxone 500 milligram IM dose. A lot of you, 92% of you guys got it right. Similarly, what is the treatment for uncomplicated chlamydia? It is doxycycline 100 milligram orally twice a day for 7 days. About 80% of you guys got it right. Drug recommendation for mycoplasma, yeah, for macrolide resistant was moxifloxacin. 90% of you got it right. Treatment for syphilis, 100% of you guys got it right. Perfect. It is benzathine penicillin. The three thing which you had to match as per column, I think that was a bit tricky for people. So you have to manage the STI condition with the most current guideline supported diagnostic or management approach. So trichomoniasis was supposed to be by NAT, that is nucleic acid amplification test. Pelvic inflammatory disease was to be matched with ceftriaxone plus doxy plus metronidazole. And BV, that is bacterial vaginosis, was metronidazole 500 milligram BV. So that was the correct answer to pick. And the last thing that was a bit out of syllabus in the sense that we didn't discuss about this was the very specific word serofast. The term serofast is used to describe which clinical scenario, and the correct answer is a failure to achieve a fourfold decline in the non-treponema test. We discussed this indirectly, that the CDC has now removed the need for doing CSF examination for patients who are able to achieve the fourfold decline. For those who cannot, the term is used serofast. Right, so those are the 10 points for the 7 questions. Everyone did great. The median score points was 8 out of 10, so that's excellent. Good. So let's just finish the last slide that I had. Where did it go? There it is. Yes. And that was actually just one slide where, if you want, please take a screenshot of this. I went through a lot of data for this presentation, but these few links are, I think, the most important ones. Okay, so if you just go through these, you will be sorted. The first 2 are articles which are published in the IJSTD, that is the Indian Journal of Sexually Transmitted Diseases, right? It was Dr. Yogesh Marfatia was the editor-in-chief for the longest time, and he has handed on the baton to Dr. Krina Patel now. She's doing an excellent job. And these 2 articles talk about the national guidelines for STIs and the updates, what they are. The third article is from JAMA. That's also a very comprehensive article for diagnosis and treatments of STIs. But as you can imagine, this is more for the US. Uh, I hope you guys are aware of this series called Clinics in Dermatology. I will not call it a journal, but it is almost like a hardbound book that comes, Clinics in Dermatology. They have a very nice 2024 March to April, s- uh, not journal, but a book that was there, has the aspects of dermatological for STD HIV updates, which you should know. Of course, NACO website, I've mentioned here the exact link. CDC has their own set of treatment guidelines on their website, which is available, which you should know. Sometimes you get asked in the exam. And lastly, WHO also has STI guidelines, which they update. So this is the website for that. These are some important resources that will help you if you are interested in STIs, or at least if you're preparing for your exams. I think with that, I'm done. That was my last slide. I hope this lecture was useful for you and will help you for your exams and also for practicing in day-to-day life. So I'm going to stop sharing.
Thank you, sir. One query from
Yeah, I'm
Dr.
just going to
Mukherjee.
that. I will just see that. Uh, where is it? Where is it? Where is it? Okay. Um, here. Let's see. So it says, in case of urethral discharge in a male, serous, not responding to kit, not responding to doxycycline, what should we do? So if it is serous, it is mostly non-gonococcal urethritis, right? Gonorrhea usually is that thick, milky discharge. So first you have to test what is it. You can do NAT testing. It is available in India. You can do it. Secondly, you can do antibiotic resistance and sensitivity testing. Depending on that report, you can get, or like we discussed, if you're not able to do it, you can add moxifloxacin along with the doxycycline, and it does work. Many a times, co-infection is the problem. You are suspecting one thing, but the patient also has other things. This is very common. So in general, in private practice, if you get a patient with one STI, assume that he also has others. So probably you want to investigate and find out what it is. That should work for most patients. You're welcome.
So thank you, sir. So let me present you the vote of thanks.
Thank you. Good.
So good evening, everyone. As we come to the end of this enriching academic session, it's my privilege to propose a vote of thanks. On behalf of Paulson's Derma, I extend our heartfelt gratitude to Dr. Kaleem Khan for sharing such valuable insights and practical clinical experience. Your enlightening presentation, backed by your vast expertise, has undoubtedly enhanced our understanding of the subject and will greatly benefit everyone in their clinical practice. I would also like to sincerely thank all the respected doctors and postgraduate students who joined us today. Your active participation, thoughtful questions, and enthusiasm made this session truly interactive and meaningful. We hope today's session has been academically rewarding, and we look forward to your continued participation in our upcoming masterclass series. One big announcement, our next masterclass program will be on the update on collagen vascular diseases, clinical perspectives by renowned dermatologist Dr. Viju Vasudevan on 7th August. Once again, thank you, Dr. Kaleem Khan, and thank you all our esteemed participants for being with us today. Have a wonderful evening, stay safe, and see you at our next session. Thank you.
Thank you, everyone. Great. Take care. Bye-bye.
Thank you, sir. Thank you all the doctors for taking out your time. A great evening ahead.